Good evening, and thank you for joining us. My name is Jeff Butler. I'm Director of Health Information Management for Concord Hospital. On behalf of the Pacing Center for Cancer Care, I want to welcome everyone to this information session regarding skin cancer awareness. Our presenters this evening are Alexandra Charos, MD, PhD, and Lyndsay Overko, PAC from Concord Dermatology. Dr. Charos, a New Hampshire native, completed her dermatology residency at the University of Vermont in Burlington, serving as the co-chief resident. She graduated cum laude with a bachelor's degree in biology from Harvard College prior to attending medical school at Temple University in Philadelphia, Pennsylvania. She completed her internship in pediatrics at Cohen Children's Medical Center in Northwell Health in New Hyde Park, New York, the largest children's hospital in New York. Concord dermatology specialists are experts in skin health, providing comprehensive dermatology services from diagnosing and treating skin diseases to restoring a youthful appearance. Dr. Charos is a member of the American Academy of Dermatology and the American Society for Dermatologic Surgery, with special clinical interests in the dermatologic surgery, general dermatology, and pediatric dermatology. Lyndsay Overko was born and raised in Manchester, New Hampshire. She received her Master of Physician Assistant at Eastern Virginia Medical School in Norfolk, Virginia. Prior to graduate school, she attended the Northeastern University, where she completed her Bachelor's of Science in Athletic Training. She has been working as a PAC for the past 12 years and has specialized in dermatology for the past 4 years. She is a member of the Society of Dermatology Physician Assistants, where she completed the diplomat program, as well as a member of the New Hampshire Society of Physician Assistants. In her spare time, she enjoys spending time with her husband and daughter. At the end of the presentation, we will provide more information on screening opportunities. Now I'll turn it over to our experts for their presentation. Dr. Charos.
Hi, I'm Alexandra Charos. I'm sitting here today with Lyndsay Overko, and we really want to thank you guys for coming to this presentation on skin cancer awareness. And we want this to be a conversation with me and Lyndsay, to you guys who are participating. There is a chat button where you can put questions while we're having the presentation, and if they're quick and easy questions, then we'll answer them while we're giving the presentation, but if they're a little more nuanced, we'll address them towards the end because we have a dedicated Q&A at the end. So we will get started. So first, I'd like to share with you a little bit of the CDC data with regards to New Hampshire and skin cancer. So in the state of New Hampshire, if you look at the bar graphs, I know it's very hard to read the type of cancers up there, but I do want you to note that the 6th most likely cancer by cancer cases in the state of New Hampshire is melanoma skin cancer, and that's on the left bar graph. On the right bar graph, it's the rate of cancer deaths within the state. And fortunately, skin cancer is not among the top, and I think that's because we're pretty good at detecting skin cancers. We're getting better and better at diagnosing skin cancers earlier. And I wanted to speak about melanoma first because melanoma is a type of skin cancer that if it does go undiagnosed and untreated, it can lead to death. And so it remains important to know what to look out for. So in terms of melanoma, melanoma can arise anywhere on the skin, including underneath the fingernail, as you can see in that picture up in the left. And there are other pictures to show that the appearance of melanoma can be quite varied. So what is melanoma? Melanoma is a malignant tumor that arises from melanocytes. Those are the pigment-producing cells in the skin. And there is a rising incidence of cutaneous melanoma which has been going on for the past 4 decades in white populations. And if untreated, as I mentioned before, it can lead to death. So we have this cute little mnemonic in dermatology. We call it the ABCDEs of melanoma, which is a way to try to remember what to look out for. And we share this with our patients, and we have little bookmarks of them. So A is the first, and that is for asymmetry. So melanoma skin cancers, if you recall in some of the previous photos that I showed, they look pretty asymmetrical. B is for funny borders, usually lumpy, bumpy borders or jagged like a snowflake. We really like the borders of our spots to be more smooth or rounded. And C is for color variation. We don't like things that are jet black in color, and we don't like things that are changing color. D is for diameter, bigger than 6 millimeters or the size of a pencil eraser. Now, this is the least important one, but the most important is E, and that is a spot that's evolving. So generally, if someone has a melanoma that they notice, it changes over a period of time. And that period of time can vary. It can be on an order of weeks or months or even years. But generally, people will notice some sort of change in size, appearance, color, and so forth. And what the ABCDEs of melanoma does not account for is some of the other variables, like spots that are bleeding and not healing. Some people come and say, you know, my mole is bleeding, but I don't remember cutting it. Those are things that you should also be aware of and be on the lookout for. So I just spoke about melanoma, which is, you know, one of the most deadly skin cancers. And now I'm going to talk about something on the opposite spectrum, which is a basal cell carcinoma. This is the most common type of skin cancer. And it is similar to melanoma in that it can have a varied appearance on the skin. So if you look on the left, you'll see a sort of a pink, shiny, kind of eroded looking papule on the skin, and that's one appearance. It can just be more of a pink, shiny, translucent bump as the second picture shows, or it can be a very large plaque with rolled borders. But what's similar in those 3 skin cancers that you can see is that they're all very shiny, and if you look closely at them, they have visible blood vessels. And I wanted to show a picture on the right, which is another basal, but if you notice, it has brown pigmentation within it. So someone might notice that they have a sore spot that's not healing, and it's brown, and they might immediately think that they have a melanoma. And you don't need to jump to that conclusion because, especially in patients who have tan skin or skin that is darker toned, they may have pigment within their basal, and I've certainly seen that. And basal cells tend to occur on sun-damaged skin, usually skin that's been, you know, more exposed to the sun. The face is a very common place for them, as is the back. And as I mentioned before, most of them are pink and pearly and have visible blood vessels. And a very common story we hear with basal cells is, I thought I had a pimple and it just didn't go away. I squeezed it and nothing came out, and it just kept getting bigger and it kept scabbing over, and, you know, I realized it's not a pimple. Fortunately, basal cells, they tend to just grow locally on the skin, but they do need to be removed because they damage the skin that they grow on. So the best analogy that I give patients for basal cells is that they're kind of like cavities of the teeth. You know, if you have a cavity on your tooth, you need the dentist to drill it out so that it doesn't keep spreading. So this is how I think of basals. They have a very low potential to be malignant, so they're on the opposite end of the spectrum as the melanomas. And now I'm going to pass it to Lyndsay.
Wonderful job. So now we're going to talk about the precancer lesions called actinic keratoses, or AKs. These are something that we see every day in our clinic. Most of our patients have at least one of these, if not many. They do tend to occur certainly pretty much only on the sun-damaged areas. Click that. So these can present, as you can see in the photo, pretty red, scaly, more gritty sensation and that just doesn't really go away with topical cream. So people will constantly say, you know, I've moisturized, I've put Vaseline, I've put every kind of moisturizer, but it's just not going away. That might be an indication that it could be an AK. These often also appear on or near the lips, and your lips can kind of just feel chapped a lot of the times, particularly around that vermilion border. Sometimes it's more discreet rather than just seeing an actual lesion there. It might just feel kind of rough. So that we definitely, want to take care of as best as we can and identify. Because each one of the AKs, does have less than 1% chance of each year turning into squamous cell carcinoma, which is another non-melanoma skin cancer that we'll talk about next. But, a lot of the times patients will say, well, it's precancerous, do I really need to treat it? You don't have to, but we do recommend doing that. There are different types of treatments when it's more localized, and there's only a couple. Most of the time we'll offer cryotherapy, so liquid nitrogen. But when they're more frequent or kind of more spread out, covering, most of the scalp or a big part of the face, even the arms, sometimes the legs, we will offer a field therapy treatment, and that can either be utilized with a topical cream, such as a chemotherapeutic, something called Effudex or Aldera. There's lots of different ones. Most of the time we use Effudex. And then there's also a blue or red light therapy called photodynamic therapy that we also offer in our clinic. And then ED&C is where we scrape and burn. We typically use this more for a superficial squamous cell, but we certainly can utilize it for the AKs as well. And I'm not sure how often you do that, but we certainly can. So lots of different treatments for those. And then it leads me into the squamous cell carcinomas, which again are very common non-melanoma skin cancer that also occurs on the sun-damaged skin. So we see a lot of this on the face, the scalp, the ears. That's another location for those AKs. And then we also see a lot of them on the arms and the legs and the chest, actually, both basal cells and squamous cells on the chest. These also tend to occur on or near the lips of smokers, so a little bit higher risk for those people, especially if they're sun worshipers and smokers. They're probably going to have something around that area. And they do tend to grow a little quicker and can become more painful. Sometimes basal cells are not as painful, but this can definitely be more uncomfortable. And when they're around the lip, it is definitely more high risk. There is a little bit higher risk of metastasizing with these, especially in a more high-risk area or aggressive subtype. So we definitely want to, identify these pretty quickly and treat them as aggressively as we can.
And often they have that appearance of having like this kind of erupting on the skin like a volcano and kind of looking like a volcano on the skin. And so we do try to treat these a little bit faster than basal cells, which can grow very slowly.
Exactly. Okay. So, and then we get to the family history of skin cancer, which is a question that we probably both get asked often. So what's my risk if I have a family history of skin cancer? And there's lots of kind of different answers to that. But basal cell and squamous cell typically occur more frequently in the patients that have, fairer skin, light eyes, that burn easily, and have that significant sun exposure. Genetics can play a role, but it's a pretty small role. So if mom or dad, had a bunch of skin cancers, I'm not as worried about you in general, unless you particularly had a hot, you were exposed to the sun or tanning beds, anything like that. When it comes to melanoma, though, these can actually occur spontaneously and can run in the families. So disease genes have actually been identified in families that can increase the risk of this type of skin cancer. So if you do have a first-degree relative, like mom, dad, brother, sister, kids, that had melanoma, then you are at a little bit higher risk. And so I always tell my patients, you should probably come see us once a year. And I think Dr. Charos feels the same way, and most of us practice the same way. And just, also be aware of what to look for, like she had mentioned earlier, the ABCDEs of melanoma, and monitoring your skin pretty closely. I always say at least once a month, and then using really good sun protection. Which also leads me to the next slide, my favorite thing to talk about, is prevention. So when we talk about sun prevention or photoprotection, it's not just about sunscreen, which a lot of us think, I wear sunscreen here and there, I don't wear it every day. Oh, I'm never out in the sun. I think most of us get I'm not out in the sun very often, or I don't go outside. Well, you probably run errands, you probably are in the car, you're probably outside in the UV exposure much more than you actually realize. So when we talk about sun exposure, we are talking about just your day-to-day, even near windows. Your car windows are not protective, except I believe maybe the windshield.
The windshield is protected.
Which most people don't realize. And so, I always keep a little, just a side note, I always keep a little thing of sunscreen or even gloves in my car. You want to think about the backs of your hands because you're on the steering wheel. But basically, seeking shade when you can is a form of sun protection. So umbrellas, going under the trees, like wearing hats and protective clothing. There's plenty of clothing lines or like lines that have sun protective, the UPF clothing. There are wonderful ones out there. And then also avoiding tanning beds. This is, I wish they were not in existence anymore.
Right, they're really dangerous.
So dangerous that we can't stress that enough. And then, obviously the sunscreen. And so I personally try to recommend more of the mineral-based sunscreens, which contain the zinc and titanium. Those are physical blockers. There are chemical sunscreens as well, or the physical sunscreens that are the oxybenzones and lots of other things. Those tend to spread a little bit more easily, and people sometimes like those, but I would say our industry is doing a much better job with the mineral-based sunscreens. And there's lots of companies out there that have wonderful products. And the higher the SPF, certainly the more protection. I always recommend between 30 and 50. I'm not sure, what do you tend to recommend?
I recommend at least 30.
Yes, exactly. Yep, and so the other key to all of this is reapplying, and reapplying every 2 hours, especially if you're going to be in that direct sun or outside, running errands for more than a few hours. Always good to be able to reapply. And do this every day. I will say that's one thing people don't understand is they always think, well, it's just when I'm in the sun. But it's really every day that you should put it on. I always tell patients, try to put it on in the morning, like your routine moisturizer. If that has it in it, great. If your makeup has it in it for females, great. But you really want to look at that number and make sure that you're reapplying throughout the day.
And I think it is important in New Hampshire. The incidence of skin cancer in New Hampshire is one of the highest rates in the country. And that's primarily because people in our state tend to be fair, but they also tend to be outdoors a lot. They like to hike and bike and ski and kayak, and all of these sports, get, direct sunlight or reflection off of the snow. So it is important, even in the months when you don't feel like it's very sunny.
So exactly. Even when it's not sunny, you're still getting some UV exposure. So yeah, I think that concludes our presentation. So if there's any questions, feel free to add them to the chat. Right?
Yeah.
Okay.
We did have a Q&A slide. I don't know what happened to it. I lost it. But if anyone has any questions, feel free to type them and we'll address them.
If none, we'll conclude.
So I just included this link because it's a public resource for reading about skin cancers. It's a little bit more detailed than what we went over, a little more nuanced.
Yeah. I do like to recommend this to a lot of my patients too, just to see more photos and get a little bit more in depth about each of those things that we talked about, and as well as other conditions, skin conditions.
But one thing that we didn't mention that I would like to mention now is that there are benign skin growths that occur with age. And oftentimes people come in for these benign skin spots, which a lot of them are a spot called a seborrheic keratosis. And those spots can be brown or black or pink and scaly, and they can look, to the naked eye similar to some of these skin cancers or pre-skin cancers. So just because there's a new brown spot on the skin doesn't mean that it's something dangerous.
Very true.
Yeah.
And we will say that's probably the number one, thing that we see that people are worried about. It's changing. It has all of those, things that the ABCDEs can mention, but it is benign. And so if you're ever questioning that, certainly try to come see us or come see a dermatologist, and, to be happy to reassure you rather than miss something that could be dangerous.
So this is Jeff. I do have a question. How do
Sure.
these types of conditions present in people of color? You talked about light-skinned people. How about people of color?
Yeah, so in terms of melanoma, people who do have darker skin tones are also at a risk for developing melanoma. Sometimes they develop them under their nails. And so that's one place we look closely at. So people with darker skin tones, they can actually have lines of pigment running through their nails. So it's important to come to us because the natural physiologic lines under the fingernails that we call longitudinal melanonychia doesn't necessarily mean that someone has a melanoma, but in darker skin tones, the melanomas can present under the nails. In terms of the basals, as I mentioned, those ones can be pigmented in people who tan. They can be pigmented in people who freckle. I've seen that as well. So there's no hard and fast rules about skin tones. We can say this tends to happen, but for everything that tends to happen, I've seen the exception.
Thank you.
I do have a question for you, Dr. Charos. When you have a direct parent history of amelanotic melanoma, what is your recommendation? And is there anything that can be done to avoid above and beyond what you mentioned?
I would still recommend the once-a-year skin checks with that family history. And if there are any suspicious-looking moles, then I would probably, sometimes I look at a spot on the skin and I say, oh, it's a little bit atypical. I'll leave it alone. If somebody has a family history, it might push me over the edge to saying it's better to be safe than sorry. And, I have certainly diagnosed melanoma in parents who had a child that was diagnosed with melanoma. So I know a lot of people think, well, what did my parent have? But in the skin, what did my child have is you know, equally important.
Thank you. Another question is, does a new mole that itches and feels numb, is that a concern?
So I mean, the thing about new moles is that adults who are over the age of, I would say 35 to 40 should not be getting many new moles. It would be definitely prudent to have a dermatologist look at a new mole if it has a funny sensation in it, pain, itch, numbness. But it could be a different type of growth. It could just resemble a mole. Yeah.
Yeah, I think that's a big question that we get a lot, or a cheap complaint of a changing mole, but it's, especially if it's newer, it's itchy, or if it's a little scaly, it's usually a seborrheic keratosis and not a mole. I think a lot of patients confuse those two. And again, like she had said, you know, coming to see us just to be on the more prudent side and just have us take a look at it is, you know, better to be safe than sorry.
We're being asked if amelanotic melanoma presents differently.
Well, amelanotic melanoma just means that it's pink. So in the course of developing a melanoma, you know, the melanoma is made of pigment-producing cells, but sometimes they do lose their pigment. So I didn't show an example of an amelanotic melanoma, but I've seen them, and they just tend to be pink bumps. And in fact, they can really resemble a basal at that point. So I remember seeing a patient in my training who had a pink bump, and she was so worried. And we said, don't worry, it's just a basal. And it came back as a very thick melanoma. And we were, you know, very, you know, we very surprised, but we also stopped saying, don't worry, it's just a basal.
Yeah. Very true. That is very true.
We do have some questions about how to set up the appointment and the 1-800 number. And I just want to reassure everyone that that will be discussed at the very end. So stay tuned. You don't need a pen and paper at the moment, but get one handy. Those are the questions that were in the chat box for now, Dr. Charos.
Okay, we're going to just try to advance the screen because there is a phone number to call.
Did you want us to put that up there, or is there any more questions for us? Or does Jeff want to take over?
Yeah, there's no more questions in the chat box. And if you can put it back to that slide, that would be great.
We're trying.
Yeah, we
don't have the thing up anymore now, or how to get to that? Like I can. Oh, there you go. Oh, beautiful.
So
there you go.
That's the phone number to our office.